Welcome to meeting number 11 of the House of Commons Standing Committee on Transport, Infrastructure and Communities. Today's meeting is taking place in a hybrid format pursuant to the House Order of September 23rd, 2020. The proceedings will be made available via the House of Commons website. So you are aware, the webcast will always show the person speaking rather than the entirety of the committee. To ensure an orderly meeting, I would like to outline a few rules to follow. Members and witnesses may speak in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen of either Floor, English, or French. For members participating in person, proceed as you usually would when the when the whole of committee is meeting in person in a committee room. Keep in mind the directives from the Board of Internal Economy regarding masking and health protocols. Before speaking, please wait until I recognize you by name. If you are on the video conference, please click on the microphone icon to unmute yourself. Those in the room, your microphone will be controlled as normal by the proceedings and the verification officer. A reminder that all comments by members and witnesses should be addressed through the chair. When you are not speaking, your mic should be on mute. With regard to a speaking list, the committee clerk and I will do the best we can to maintain the order of speaking for all members, whether you are participating virtually or in person. Pursuant to Standing Order 108.2, the committee is meeting today to continue its study on the impact of COVID-19 on the aviation sector. Before I introduce our witnesses, I do want to ask members of the committee how long, in fact, do you want to, it's up to you, it's your choice, do you want to bring this meeting to? Do you want to shut it down at 5:30 like we usually do, which we're scheduled to do? Or would you like to go the extra time as we may be allowed by House resources being available to us? So Ms. Kusi from the Conservatives, do you have a preference? And I'll ask Mr. Backrack and Mr. Back and Mr. Russell to develop the same question. Ms. Kusi?
Yeah, thank you, Mr. Chair. I think we are considering maybe an additional half hour till 6. We did that format the other, Tuesday, I believe, and that seemed to work well. I don't think we need to do the extended 2 hours. And I recognize, of course, we're getting to the very end of the session here today and tomorrow. And I'm sure members have things that they need to wrap up both in their constituency offices and for those of us in Ottawa as well. But I think 6 will allow us to get a good 2 rounds in for everyone and hopefully get the information we need from these witnesses here today. So that's my suggestion, is extending the meeting a reasonable half hour. Thank you, Chair.
Thank you, Ms. Kusi. Mr. Barcelou-Duval?
Merci, Monsieur le Président.
Thank you, Mr. Chair.
Thank you. I would like to say that I'm comfortable going until 6 p.m. if that is the will of the committee. And if another time is decided, how can I say this? I will agree with the majority. I have no specific urgency. Of course, I have other commitments, but I can adapt. Thank you.
Thank you, Mr. Barcelou-Duval. Mr. Backrack?
Thank you, Mr. Chair. 6 p.m. works well for me.
Wonderful. Thank you. And thank you for that, members. All members are fine, 6 o'clock? We're all good? Okay, it's my pleasure now to introduce our witnesses. We have Dr. Isaac Bogosh, physician and scientist, Toronto General Hospital and University of Toronto. Dr. Bogosh, I got to admit, you look kind of young to be a scientist and a doctor. You must have flew through school at a young age.
It's the lighting.
Welcome, doctor. We also have Dr. Zane, and if I'm pronouncing your name wrong, please forgive me, Dr. Zane Chagla, Assistant Professor, Division of Infectious Diseases, Faculty of Health Sciences at McMaster University. From Lumen Ultra Technologies Limited, we have Mr. Patrick Taylor, Global Business Development Director, New Markets. Gentlemen, welcome. I'm not sure who wants to go first, but I do have an order that I was handed, so I think I'll start off with Dr. Bogosh first. Mr. Bogosh, or Dr. Bogosh, the floor is yours for 5 minutes.
Thank you so much, and thank you very much for the invitation to speak at the House of Commons Standing Committee on Transport, Infrastructure, and Communities to discuss the impact of COVID-19 on the aviation sector. I don't have a ton of time, so I'm going to jump right in. And let's start with two key issues and then some solutions. Issue number one is clearly the protection of travelers and personnel, which means crew and others who work in the industry from COVID-19. And of course, issue number two is the impact that national and international travel will have on the spread of infectious diseases, including COVID-19. So let's start with the first one, which is the protection of travelers and personnel. In general, from an infectious disease transmission standpoint, flying is a pretty safe thing to do. There's a common misperception that people frequently get infections from air travel. However, the perception of risk is disproportionately high compared to the actual risk. There's certainly cases of infections, especially respiratory infections, transmitted on planes, and there certainly are credible cases of COVID-19 transmitted on planes as well. But these are actually rare events, and they're especially rare when you consider the volume of people traveling. There's growing data, including Canadian data, to back this up. So why is this the case? You'd think that planes are exactly what we've been told to avoid. They're indoors, close, crowded, confined spaces, and that's where the virus is most easily transmitted. But planes are engineered beautifully, and the ventilation system coupled with universal masking makes air travel much, much safer. There's good data demonstrating this nationally and internationally, and we can delve into that later if anyone wishes.
Dr. Bogash,
Yep.
if I can just interrupt for a second, can you get your mic a bit closer to your mouth?
Absolutely. Can you hear me now?
Yeah, the interpreter's having a tough time, so if you can get it just a bit closer,
Okay.
that would be wonderful.
Please,
Carry on.
please redirect me if there's any issues moving forward.
No problem. Carry on.
Thank you. People need, number one, real protection from infection while flying. And number two, they need to understand how they're being protected and transparency on what and where the risks are such that they can make informed decisions. This will build confidence back in the aviation sector. I'd like to touch on the other important area, and that's the impact of national and international travel has on the spread of infectious diseases, including COVID-19. This is a problem. I've been studying this for years and have evaluated how other infections move regionally and globally through human mobility patterns, including via air travel. Diseases like Ebola, Zika, chikungunya, and more recently COVID-19. We actually even looked at international spread of this infection in early January before we knew it was a coronavirus. As people move, they bring infections with them. And if the aviation sector is to be up and running at full tilt, this has to be acknowledged and addressed. So how can we facilitate safe and ethical travel and allow the general population to have confidence that their safety needs are being met? I think we can do this with 6 big steps. Step number 1, we have to expand the focus of safety beyond the airplane itself. So we should focus on travel beginning from the time one leaves their home to the time they arrive at their final destination. Attention to each step of travel, like public transit to the airport, checking in at the gate, lining up to get on the plane, will provide incremental safety to travelers and build confidence in travel, which will help the aviation sector. Number 2, public education. Directly related to the point above. It's one thing to expand the scope of safety, but this has to be meaningfully communicated to potential travelers to ensure it is realized and operationalized. Step number 3, integration of rapid diagnostic tests. There are an increasing number of products and improving characteristics of these tests. They can be extremely helpful in the aviation sector, and they can be mobilized to tremendous capacity. Number 4, vaccination in Canada. Vaccine rollout in Canada is starting. It's probably starting next week, and this will clearly provide significant protection and confidence to Canadian travelers. And we will likely see public health measures slowly lift as 2021 moves on and more Canadians are vaccinated. Still, with more Canadians vaccinated, there'll be greater confidence in air travel because there will be less fear of people getting this infection. Number 5, global vaccination. We have to support global vaccination initiatives, and we do. There's a program called COVAX, which is an international collaborative effort to secure vaccines for low-income countries, and Canada is participating on it. This is clearly the ethical thing to do, but will also make for safer air travel and build confidence. And lastly, number 6, we really need active participation of the aviation sector in national and global infectious diseases surveillance activities. This can come in many forms in terms of screening passengers, screening wastewater on airplanes, swabbing surfaces, etc. But participation in this process can help national and global efforts to combat the spread of emerging infectious diseases, such as what we've seen with COVID-19. I thank you for your time.
Thank you, Dr. Bogash. We're now going to move on to Dr. Chagla. Dr. Chagla, for 5 minutes, the floor is yours.
Thank you, everyone, and thanks for inviting me here today. I will say that Dr. Bogash stole a bit of the thunder here, so I'm going to just follow up with a couple of points, really focusing on some of the infection control implications of flying, just to expand on a couple of Isaac's points. So, as Dr. Bogash had mentioned, airlines or airplanes seem like a terrible idea. They're a tube, hollow tube where people are stuck together for a significant amount of time. But airlines do have a specific ventilation system that is incredibly efficient, and so air travels up from the ceiling, down around passengers, down through the floor in a laminar direction. It's mixed with external air and HEPA filters, and there's about an air exchange every 2 to 3 minutes. Uh, Comparing that to typical settings, a typical household setting is 2 to 3 air exchanges per hour. Most hospitals aim for 15 to 20 air exchanges per hour. So this is in the ballpark of what would be in an operating room in terms of the air exchanges, air filtration, and mixing with external air. And it does show in multiple studies. There was a large study done by the Department of Defense in the United States where they essentially had a mannequin with fluorescent tagged aerosols that was kind of spewing out on the flight and sensors set up around all these mannequins. They repeated the experiment 300 times in different positions along the plane. It was a Boeing, a typical jumbo jet. And essentially, we saw 99.99% of the particles filtered. They lasted in the environment in any detectable quantity for 6 minutes, which is again extremely remarkable and in consideration with what we would expect in healthcare settings. And then, add on to that we still have these universal controls on airplanes in terms of masking and otherwise screening, and some airlines even requiring testing as part of their entry criteria. There is a number of different things that make air travel relatively safe. Just to speak on real world experience, so I work at McMaster. We've done an interesting study of airline travelers that have come off Air Canada flights at Pearson, where they were invited to self-directed nasal and oral testing as part of their epidemiology look. About 0.7% were positive on entry. A good number of those were actually probably people that had acquired it at their location, likely had cleared and traveled. But there are a significant number, probably in the 0.5 range, that are actually truly infectious on those flights. And considering that, if you have a flight of 200 individuals, which is not that much dissimilar to some of the large aircrafts, you have one person per flight that's positive. I mean, we see so many exposure notices out there, and in the literature, there's a couple dozen case reports of people that have truly acquired it on flights, particularly in that early part where we weren't masking, where things were still uncontrolled, where people weren't necessarily getting it from their destination. Their only exposure would be the flight. There's very, very few cases documented in that sense. Really is a good proof of principle that the flying experience is relatively safe given all the controls and the ventilation associated with it. These studies are very hard to perform now, clearly, because we have such global transmission. If I get on a flight in India and end up in Canada positive, is it from being in India? Is it from being on the flight? It's very hard to detect now because of the global penetrance of this disease. That really is my 2 cents. I think from the infection control standpoint, flights are relatively safe as long as these controls are in place. There's good experimental evidence to suggest with everything in place, going on a flight, as Dr. Bogash mentioned, everything prior to the flight and everything after the flight is probably a much higher risk than the actual flight itself, as long as the ventilation systems are working. And moving forward, I think this is a part of the safety plan of opening up flying going forward, being transparent about this type of information, particularly conveying the risks. And as we're hearing about exposure notifications every day from flights coming in and out of Canada, as well as regional flights, really putting that into the context of the number of travelers that have truly tested positive, that their attribution is truly secondary to the flight, which is fairly minimal considering the global literature around global flying, even during the pandemic.
Dr. Chagla, thank you. Well done. I'm now going to move over to Mr. Taylor. Mr. Taylor, I do understand that you're working off your laptop mic. So the closer you can get to that mic, the better. Or whatever you're working. Yeah, the closer you can get to that, the better. Chairman. That's fine. If I have any problems from the interpreters, they'll notify me and I'll notify you. You have 5 minutes. The floor is yours. Welcome.
Thank you very much, Mr. Chairman, for the opportunity to speak at the committee today. Lumen Ultra Technologies Limited is a wholly Canadian-owned company headquartered in Fredericton, New Brunswick. We were founded 25 years ago and have an extensive history of rapid, portable, molecular biology-based diagnostic testing solutions. We are a Canadian success story and a growing company. In 2018, we acquired Instant Labs of Baltimore, Maryland, and just last month we acquired Source Molecular of Miami, Florida. Prior to the pandemic, we were an internationally focused business with 90% of our customers outside of Canada. We are primarily focused, we're primarily focused originally on the water-related industries, serving the sectors of drinking water, aviation, and oil and gas. I myself am based in the UK and joined Lumen Ultra in August 2019 as Director of Global Business Development. And today I join you from Mexico, where I've been speaking at the annual conference of the Latin American Caribbean Transport Association. On March 20th, Lumen Ultra responded to a call from Canada to help build a domestic testing supply for COVID-19. On April 9, we began delivering 500,000 test equivalents per week to the federal governments and each of the provincial governments through a contract with the Public Health Agency of Canada. We continue to be the key supplier of COVID-19 testing reagents to the Canadian governments. The daunting challenge of the pandemic has also created economic opportunity. By working with a Canadian company to build this supply, government has enabled us to create further growth of jobs and economic impact right here in Canada. Since the pandemic, we've hired over 60 additional personnel, grown our workforce to over 140, and have constructed and opened a new multi-million-dollar state-of-the-art production facility in Fredericton. In May, we launched the complete environmental surveillance test for COVID-19. Environmental surveillance testing includes testing of surfaces and wastewater for the presence of the virus. By testing for the virus, it's possible to identify an infected person that has interacted with any space. But that considered, a waiting room or an aircraft is a possible point of transmission. This surveillance testing is non-invasive and can produce important insight into the health of the population interacting with these spaces. On November 27th, Health Canada approved our complete clinical test. We now provide a complete end-to-end solution for human testing, including consumables, testing devices, and testing chemicals. Unlike other rapid tests, our test is built on PCR technology. PCR testing is the gold standard test, providing rapid, accurate results. And unlike antigen testing is proven to be much more effective, particularly in identifying asymptomatic or pre-symptomatic carriers. Our PCR testing devices range from a small portable point of need device capable of running up to 16 samples in under 2 hours, to a high capacity unit capable of running 96 samples in under 2 hours. This is fully scalable as a solution. Multiple machines can be run in parallel to run as many samples as needed, with results again in under 2 hours. Lumen Ultra has spent many years working with the aviation industry and understands the unique challenges and opportunities the industry faces. We are seeing the industry use testing to respond to the significant challenges of COVID-19, including in countries throughout Europe. PCR tests are done at airports after passengers land, requiring passengers to self-isolate only while waiting a few hours for their results.
1 minute.
Yes, Mr. Chair?
Go ahead, Mr. Tilley. I was just informing you that you have 1 minute.
I beg your pardon, sorry. Supporting an investment in additional PCR testing capacity will allow Canadians to complete essential travel more safely by allowing multiple types of testing, including surfaces and wastewater, for a more complete, non-invasive insight into the health of interactions, providing opportunity to reduce long self-isolation periods by providing measurable, reliable clinical testing, and establish best practices as we head into greater vaccine availability ensuring testing protocols are in place, understood, and complied with before travel commences. The aviation industry have been deeply affected by the global pandemic. While news of a vaccine is promising, there will be continued need ongoing for testing to ensure that we do not leave our communities open to potential risk. We are proud to have been part of Canada's COVID-19 testing solution since the beginning of the pandemic, and we hope that we are able to use our Made in Canada solution to help Canada survive through the balance of the pandemic and thrive and recover as Canada returns to normality. I look forward to your questions. Thank you, Mr. Chairman.
Thank you, Mr. Taylor. Well done. We're now going to start off our first round of questions, 6 minutes each. We have Ms. Cussy, followed by Ms. Jessic, followed by Mr. Duval, Ursula Duval, and lastly, Mr. Backrack. Ms. Cussy, you're on the floor for 6 minutes.
Thank you, Chair, and thank you to all of our witnesses who are here today. Merci aux témoins qui sont ici aujourd'hui. Dr. Chagla, further to your McMaster study, in your opinion, then I understand in having met with your colleagues that there were two objectives. The first one was to actually see infection rates upon arrival after 7 days and after 14 days. And the second one was to see if, given this information, if it was possible to reduce quarantine, as we've seen done in other nations. In your opinion, after the tests being completed and the data you have seen, is it possible to reduce quarantine?
Yeah, so they've released about a month of data from their first initial pilot. They are still looking at the October data from their pilot now. The rate of people that test positive at day 7 who don't test positive on day of arrival is still not insignificant. It's small, but it's, I think, 0.2 or 0.3% that don't test positive in that first batch. 0.3 exactly. So, I think if you capture most of the people in that range, so that, you obviously cut off the people that test positive immediately. And so that would be, the bulk of people that are infectious coming in, where it's probably related to their days of experience prior to coming in the country. And then you have a period of, again, 7 days post to deal with, people that may have been exposed in transit airports, people that may have been exposed along their path that should be PCR positive. You would get the bulk of people if you test them on day 7. Is there a chance of 1 or 2% sneaking out? For sure, but at the end of the day, even the CDC has updated their guidance for people that are exposed to COVID-19, not in airline travel, but just generally exposed to someone who are probably the highest risk people out there, that day 7 with the test is enough to release someone from quarantine in that sense. So realistically, it should be the same post-flight because the risk is actually much smaller in that sense. It's not an exact exposure, it's a random chance in that sense.
Yes, and thank you so much, Karen. My understanding is the one, they actually think it might be people who are in fact breaking the quarantine due to human nature, of course. Why do you think, Dr. Shagla, it's taking the Canadian government or I should say airport authorities even so long to implement this rapid testing process that other airport authorities across the country, given the relative success that we saw not only with that pilot, but in my hometown of Calgary, the success that we're seeing there with this operation? Why do you think it's taking so long for the government to implement?
Yeah, I mean, it's a good question. I think I know the people who I work intimately at the lab focus from McMaster. They're very innovative. They have a lot of capacity to deal with this type of testing. The reality is, there's a hierarchy of needs, and unfortunately, the highest priority on the hierarchy of needs currently is people that are symptomatic with COVID-19, people that are exposed to COVID-19, long-term air outbreaks, hospitalized patients, And so, with turnaround time still not being adequate for many individuals, it's a question of whether or not you want to expand capacity without the ability to actually expand and flex that capacity in that sense. But I agree, there's lots of different ways to innovate it. I mean, my colleagues at McMaster, who you just chatted with, have looked at different mechanisms in terms of pooling, in terms of robotics, in terms of other methodology to really get testing scaled up to a quantification that's
Sorry, Dr. Chagla, I'll go in quickly. You mentioned something important, and that's something I know we're looking as we are prioritizing the most vulnerable for the vaccine. Would you say that crews, pilots, flight attendants, etc., should be placed upon in this first group since they are exposed, have this exposure on a regular basis? Based upon your information, which I've done the math too. I'm like, oh my gosh, that's like one person every flight. So I see what you're saying.
Yeah. I mean, so I also ask Dr. Bogesh to weigh in here because he sits on also a fairly large provincial vaccine committee.
I'm aware. Yeah.
So, I mean, I think from my standpoint, in the NACI recommendations, which are federal recommendations, there is a recommendation for front-facing individuals, but not in the first wave of vaccinations. That is kind of down the list after healthcare workers, long-term care residents, vulnerable individuals, and then front-facing like firefighters, teachers, police officers.
Okay, thank you, Dr. Chagla. I'm going to go to Dr. Bogosian because I have a minute left. Could you comment then, please, on priority? And then also, if you can touch on, you talked about surveillance. I'm wondering what entity you see responsible for that internationally. Would it be IATA? Would it be the World Health Organization? And finally, as we see inequality within vaccination, perhaps you could comment on immunity passports in 50 seconds, Dr. Bogosian.
Oh, that shouldn't be a problem at all. So let's start with immunity passports. I think we need to poll the Canadian public because there's very polarizing thoughts on this. I can certainly see some benefits if you, and obviously some clear drawbacks, especially some major equity issues with that. Related to surveillance on airplanes, I see this as public-private partnerships. They're essential. We know that human mobility is responsible for so much of the transmission of infectious diseases nationally and internationally. Look at our non-existent influenza season we're having so far. I don't want to get too overconfident because it's just the beginning, but we can see how human mobility significantly contributes to the spread of infectious diseases, and public-private partnerships through some formal program that we can think of, be it IATA, be it whatever. But that needs to happen. And in terms of priority populations, I completely agree with Dr. Chagla. While front-facing individuals who are part of the essential functioning of society should be prioritized, that includes teachers and other members that Dr. Chagla had mentioned, and that certainly could include crew. It would be below the priority of people at risk of severe infections, such as those in long-term care facilities, Indigenous populations, and other groups that were mentioned in the NACI guidelines as the first tier for people who should be vaccinated.
Thank you, Dr. Bogesh.
Thank you, Chair. I was going to ask Mr. Taylor if he was staying at the Four Seasons in Mexico City. It looks familiar, but I'll save that for another round. Take care. Thank you.
Thank you, Ms. Kusi. We're now going to go on to Mrs. Jacek for 6 minutes. Ms. Jacek, the floor is yours.
Thank you so much. And thank you to all the witnesses for being here and giving excellent testimony. And in particular to the two physicians, thank you for what you've been doing with the news media. I've heard you both, and I think you're really helping Canadians interpret the situation with COVID-19. So, Dr. Bogosh, just to start off, certainly you referenced the precautions that are being made on airlines. And so you know that Canadian Airlines did follow IATA recommendations. They were instituted basically in July. You mentioned, and Dr. Chagla mentioned, the filtration system, masking. There's also temperature checks. If you look at data, are you able to, I mean, obviously none of this is in any way harmful to, as an example, do a temperature check. Are you able to sort of in any way quantify the most valuable type of intervention? It sounds like filtration, air turnover, and so on is the most important. Would you just confirm that?
Sure. So just a couple of notes. I helped with those IATA recommendations. A lot of those were conjured up in March in Singapore, which was my last trip before everything shut down. So I'm aware of those, and I think they're pretty strong because there was broad consultation with the World Health Organization and ICAO as well. The second thing is I don't think there's going to be one step to make things safe. It's really a bundle of measures taken together that will make airline travel safe or safer. As I mentioned, I really think we have to focus on the point of origin to the point of destination and everywhere in between, and that will really ensure proper safety. Of course, there's only certain things that are under the control of the aviation sector, but if we really focus on a more holistic approach, including education, we can make travel safer and instill greater confidence. Directly related to the plane itself, the air filtration system and ventilation system of the plane is spectacular. You couple that with universal masking, which is also extremely helpful, and really crowd control as best as you can, getting on and off the plane while that ventilation system might not be functioning. So those are all very high yield components. Of course, hand hygiene is also important, and all the other public health measures that we've been discussing, but those would be the highest yield in my opinion. Again, it's a bundle. Last point, temperature checks. It was really interesting. Don't laugh me off this call. Initially, they weren't being done at Canadian airports, and everyone said, "Whoa, we're not doing temperature checks. We need to do them." And then they were doing temperature checks, and everyone's saying, "Whoa, they're useless. We don't need to do them." It's optics. It's optics. You're not going to get it's with this infection. You're not going to. You've got to have the right fever at the right place at the right time, and it's a lot of optics. I don't think that's bad. I don't think that's bad. It might have some people have a little more confidence in traveling, but it's that in and of itself isn't going to make air travel safe.
Thank you. So now turning to rapid testing. Certainly in early days, I think there was a lot of questioning around the reliability. So maybe Dr. Chagler, if you could just inform us what's being used now, what is the sensitivity, specificity, false negative, false positives that you know of at this point in time?
Yeah, so the major rapid test that's available on the Canadian market right now is the PanBio by Abbott. This is a lateral flow assay. It looks very much like a pregnancy test. People get a nasopharyngeal swab, and from what I understand, Health Canada is actually looking at approving nasal swab to make it a little bit more tolerant. It's put into a tube. The tube's dropped onto a pregnancy test, basically, and you wait 15 to 20 minutes for a result. Sensitivity, and again, this is approval as compared to PCR in people that are symptomatic, is about 75%, specificity 95%. That being said, the sensitivity improves in people that have very high levels of circulating virus. And one of the things that got discovered in the McMaster study, as we know, PCR tests tend to stay positive in some individuals for some time. It's not a reflection of their infectivity, it's a reflection of shedding virus. And so, that is a double-edged sword in that sense, where if you PCR everyone that comes back, you may have to wait time, you may get data that may not actually be usable. And Dr. Smea, who's part of that study, really did pick up a lot of people we call with high cycle thresholds and low viral, very low levels of virus. These rapid tests may pick up the people that are more clinically relevant, the people that are actually infectious and a threat to people, rather than picking up the people at the very early ends of their disease and at the very non-infectious late ends of their disease. And so, we are looking at these tests in long-term care. We're looking in these tests for surveillance for other populations, recognizing that in someone that's symptomatic, I don't want to give them this test necessarily on its own. But if it's someone that's asymptomatic, that's feeling fine, and I get a positive, I'm treating that as if they're positive, because they're probably asymptomatic and infectious and walking around, basically. So, it's a double-edged sword. I think these tests, as Dr. Bogish mentioned, actually do have a role in this type of testing, just for rollout, for lowering laboratory requirements. And again, if you use them serially, they're effective too, as long as they're done properly. Plus, again, the training can be done outside of the laboratory, not in the laboratory.
From previous testimony, we have heard potentially for the role of pre-travel testing. And perhaps, Dr. Bogosh, you could comment as how you might see that we refine what we're doing now.
Sure
quick
thing.
answer,
So,
please.
pardon me?
A quick answer, please. We got
Absolutely. So
30 seconds.
I think rapid testing, we're just using that as an umbrella term. There's certain products available. There's going to be more that are going to come onto the market soon. We have to remember the goal here is not to detect infection. We're trying to detect people who are at risk of transmitting infection. That's the goal. That's slightly different. Who's going to transmit, not who's infected. So that's a separate question to ask, but that's the important question to ask, and that's what rapid tests are addressing. The next thing is that, I think there would be a role for them. They're not going to be perfect. They're of course not going to be perfect. It's not a foolproof, safe, perfect solution. It will just incrementally add safety to air travel if it was done pre-travel.
Thank you, Dr. Bogosh. Thank you, Dr. Jacek. So we now heard from the Conservatives, Ms. Kusi, Liberals, Dr. Jacek. I was thinking, Dr. Jacek, when you were speaking there and asking those questions, in your former capacity as the Minister of Health in province of Ontario, how you'd be tackling some of these issues in that capacity. I'm sure you think about that often. Now we're going to go on to the Bloc Québécois with Mr. Barcelou-Devel. Mr. Barcelou-Devel, you have 6 minutes.
Thank you, Mr. Chair. My first question is for Mr. Bogosh. Earlier, you answered a question by saying that the main vector for the infection spreading is persons. And I don't know if it was you or Mr. Shagla, but you say it was the air filtration systems in planes, combined with the fact that people wear masks, there's very little chance that you catch COVID on a plane. However, the mobility of people prior to the flight or after the flight, there is a more possibility of spread. Would you agree with that? Mr. Moga, you are on mute.
Yes, I would certainly agree with that. I can go on if you like. But yeah, I mean, the flight itself, you certainly can transmit on an airplane. There have been credible cases of COVID-19 transmitted on planes. We have to come away from this acknowledging that it's just much, much, much less likely than what people would think. But certainly the other components of travel are also very important to address, because we shouldn't just focus on that tiny part of the puzzle, which is the airplane itself. If we think more holistically, we can improve travel safety and instill greater confidence in the aviation sector by looking at every aspect of travel, getting to the airport, getting on the plane, and going from the airport. We can break it down if everyone has time later into each one of those components and how to make each one of those safer. I've thought it through with my colleagues, and we've written papers on this as well.
Mr. Barcelou-Devel.
Merci, mais
Thank you. In those circumstances, then, if you can maximize safety in the plane and in the airports as well, then risk of travel remains there, however. And my next question is on the reliability of the tests. These rapid tests are going to catch a few. If you can imagine a filter and the mesh is of a certain size, but there are asymptomatic persons or ones who are at the very beginning of their infection, and they wouldn't be caught by these rapid tests. Is that something that concerns you, that so many people would actually get through the mesh of the filter?
Dr. Bogosh.
No, what I was mentioning before is that we're really looking for multiple tiers of protection, and the rapid test is just one of many levels of protection there. It will certainly provide incremental safety, but by themselves, it's not going to be the savior and to make airline travel perfectly safe. It will certainly add incremental safety, though.
Mr. Barcelou-Devel.
Donc, je comprends bien que c'est un plus.
I've understood that, therefore, then to have these rapid testing is a plus. Now, regarding reliability, some of the rapid tests and the data we've seen in Quebec, and it's the reason why the Quebec government haven't used it yet, is because of the false positives or the false negatives. So with a high rate of error, can you actually consider these tests as being reliable? And perhaps Dr. Shagla could also comment on this.
Yeah, they're a single test. And so, you take the results along with the type of patient you're testing, right? If your probability of that person having COVID is low, they're asymptomatic, they're feeling fine, and the test is negative, yes, the sensitivity says that you might miss a few of them, and that negative may actually be a positive, but your probability of them going in being positive isn't that high to begin with. And so you have to combine those things. The use of serial testing too as well. So similar to what they're doing in Calgary, day 2 and day 7, that also helps with increasing that sensitivity, saying that even if you got caught too early on that first test, you still have time to get a viral load that's higher on the second test and get picked up. So again, these aren't perfect tests. You would still have to get positives, treat them as positives, but you can still do PCR on them. And we have other models of infectious diseases where we do a screening test and a gold standard test for positives. So there certainly are ways to make it work such that you don't necessarily overcall positives. The negatives, yeah, it is the right context. Serial testing helps, but you could certainly miss a couple of positives here and there. It's much less likely in people who you don't suspect being positive to begin with, though. So if I'm in an emergency room testing people and I get a negative and someone has a fever and a cough, I'm not going to rely on that result. If I'm walking out on the street and I swab someone and it has a negative, and their probability of having COVID is pretty zero if they're feeling fine, then yes, I'm going to rely on that negative as a real result.
Mr. Barcelona.
Merci.
Thank you. So, in an ideal world, what would you need so that you didn't miss out on any positive cases? Earlier, you talked about a 7-day period for isolation. In Quebec, public health has talked about 14 days. That's been what's been recommended to the public. How do you explain the difference between the 7 days and the 14 days?
So most individuals that are positive, who have been exposed, show up with their symptoms early. So in the first 3 to 5 days post-exposure. And if you track people in terms of, my family member was positive, I was exposed, when do I develop symptoms? When do I have a detectable viral load, which is often 48 to 72 hours before symptom onset? If you kind of map that out from the gross majority of individuals, they're going to show up positive by day 10, and they're going to have detectable virus by day 7. And so that's where that consolidation comes out and where the CDC guidelines have changed, in the sense that you might miss 1% in that tail between 10 to 14 days, but it's very unclear if that's even clinically relevant in most individuals. And so if you release people by day 10 who are asymptomatic, you probably have caught most of your individuals there. And if you want to release them earlier, by day 7, most of those people that are symptomatic by day 10 should probably have a detectable PCR or molecular result at that point. So that's where that advice has come from. It's an evolving field. Again, 14 days was the standard from the beginning, but again, knowing the natural history studies of people after exposure, it's much likely, the gross majority of individuals are going to be PCR positive by day 7, and again, positive for symptoms by day 10.
Thank you, Dr. Chagla, and thank you, Mr. Barcelona. We're now going to move on to Mr. Bacharach for 6 minutes of the NDP. Mr. Bacharach, the floor is yours.
Thank you, Mr. Chair, and thank you to all of our witnesses for appearing today. Talking about continuing the conversation around rapid tests, Dr. Chagla, I'm really interested in this idea of comparing the risk between the current 14-day quarantine and what's being proposed under these rapid test pilot projects. If you were advising a decision maker and the decision maker wanted the lowest risk approach to international travel, which of the approaches would you recommend?
If you're looking for an outcome to have 0 cases show up that could be infectious to the community, then yes, you would go with the 14-day approach, because you're going to miss 1 of 100 going down that road. The CDC, when they focused on shortening the quarantine period, it was accepting that a 14-day quarantine is hell for a lot of people. It is very difficult. And you want to incentivize people to do the 7 days properly rather than doing 7 and then taking a quick trip to the grocery store at day 10 and then go, you know what I mean? So if you're going for just numbers, then yes, then the 14 days would be adequate. If you're going for practical compliance of a population to adhere to a quarantine period, then day 7 presents a whole better opportunity to get people out earlier and adhere to those first 7 days where they're critical more than anything else.
Okay, thanks for that. Going to the McMaster study here at Pearson and looking at the results, it looks like, of the 1%, 0.7% were caught in the first test, 0.3% after 7 days. Those seem like really small numbers when they're expressed as percentages, but doesn't that essentially tell us that fully a third of the positive cases were missed in the first test?
Yeah, absolutely. So that 0.7%, are related to people, and again, some of that was related to people that were positive, that were non-infectious, but still shedding, that went on a flight and got back to Canada, and probably got infected in their place of origin in that sense. But there are some that were caught there that were actually infectious, and yes, that 0.3 gets caught a little bit later. The people that were incubating on that flight that were negative when they showed up, but by the time they end up in Canada for a couple of days, they're now positive on testing in that sense. So yeah, there is a part that's missed, which is why you do have to institute some period. Um, uh, it's just much better again for day 7. If you're going to catch most of them, that's probably a much more tolerant period for everyone else. Plus, you're going to catch people even who might be symptomatic day 9 or 10, because we know they start shedding on day 7 in that sense too.
Right. Okay. Shifting a little bit, I'm wondering either Mr. Shagla or Mr. Bogosh, the question of the cost of rolling out these rapid tests across airports in Canada. And, even if we were to cover a percentage of international flights, do we have some sense of the investment, or perhaps even Mr. Taylor, some sense of the investment that would be required to roll this out in the way in which the major airlines would like to see it implemented?
I could take a quick stab at that. And I think the important thing to consider here is there's what we have available now, but that's rapidly evolving too. So in the pipeline are, you know, inexpensive, easy to use, rapid screening tests. They're not diagnostic tests, they're screening tests. Cheap, easy, point of care tests. Are they going to be perfect? Of course not. We're just talking about adding another layer of protection. And I think they're, when purchased on bulk, it seems like it would be a very feasible thing to do. That doesn't exist just yet, but it will shortly.
Okay. So do you have any sense around the cost? I guess the reason I'm asking is that my understanding is that what's being called for is something that will reduce or even eliminate the requirement for a quarantine. What Mr. Shagla is talking about around reducing the quarantine from 14 to 70 or to 7 days doesn't eliminate the inconvenience of quarantine altogether. And so I'm just wondering if it's worth this investment, because we have scarce resources and we want to invest them in the areas where we can have the best impact on reducing transmission and addressing the overall pandemic. Is it worth investing as a country in if we can only get the quarantine down to 7 days?
Right. So I think I'd mention 2 quick points. One is we're talking about there's pre-travel testing and there's post-travel testing, and now we're talking about post-travel testing, just so we're clarifying things. The second thing is we don't necessarily need rapid diagnostic tests for that. You can use conventional diagnostic tests and bring people into a conventional diagnostic testing center to do that. And then I think it would be very helpful to have a health economist look at it and look at the cost effectiveness and cost savings of having people out of the workforce, potentially out of the workforce, or whatever inefficiencies you have working from home over a 14-day period of time versus a 7-day period of time, comparing that to the cost. That's an answerable question, and it would require someone to it could be done. It certainly is an answerable question. I can't do that on the back of an envelope here, though.
30 seconds, Mr. Bacharach.
I appreciate that. Last question for Mr. Bogosh. Just your point around international vaccination, global vaccination, really interested me. And you mentioned COVAX. I'm just wondering what Canada's funding levels for COVAX have been, if over the past decade or so. Have we been adequately funding that agency to ensure that countries with more scarce financial resources than ours are able to vaccinate effectively?
Yeah, certainly Canada's been very good on the international front, but COVAX is interesting because it was just I was going to use the word cobbled together, but that's probably not the most appropriate term. It's through an alliance with the WHO and Gavi, which is a big international vaccine institute. And the whole point was to gather a bunch of countries together to get buying power for COVID-19 vaccination so that they weren't muscled out of this by high-income countries. I think it's going to be successful. It's clear that they're going to be later on, and lower income countries and low middle income countries will be vaccinated. Certainly not not anytime soon, but they will get access to vaccines. And many countries, including Canada, have paid into this. And so I'm very happy we're supporting it.
Thank you, Dr. Bogosh, and thank you, Mr. Bachrach. We're now going to move on to our second round. We have for the Conservatives, Mr. Shipley for 5 minutes, followed by Mr. Sadu for the Liberals for 5 minutes, Mr. Barcelona Duval from the Bloc Québécois for 2.5 minutes, Mr. Bachrach for 2.5 minutes of the NDP. Mr. Shipley, floor is yours for 5 minutes.
Thank you, Mr. Chair. And our committee, we've been talking a lot about, obviously, the impacts on the aviation sector with COVID. There's been a lot of questions so far about the rapid testing. I'm going to change a little bit and try to key in more on the vaccine aspect of it, because I feel that really to get the airlines and aviation back to normal, which is an interesting word these days being bantered around, is to really try to deal with the pandemic itself. And that's obviously hopefully through the vaccine. So I'm going to gear a lot of my questions through Dr. Bogosh, who I do have to admit, I'm looking forward to having a discussion with you, Mr. Bogosh. You've become almost a little bit of a COVID star through the news media. I knew I'd make you smile there a bit. I'm going to say you're almost a bit of a COVID celebrity, and I'm sure you're getting lots of people recognizing you, because I definitely do. I watch the news a lot, a bit of a news junkie, and I definitely knew the name right off the hop, and I was looking forward to talking to you. So great job for all you've done over the last many, many months. You've kept a lot of people informed. So my questions are going to be a lot to yourself, sir. The question that I have right off the hop is, so once someone has successfully had both vaccines, when I say both, because a lot of them, the ones we're getting right now, take 2 doses, will they be able to travel without quarantine restrictions?
That's a great point. So the short answer is I don't know. I just don't know, because we don't actually know yet about what we do know about these vaccines is that to date, if someone gets the vaccine, they're much less likely to have symptomatic COVID-19, significantly less likely to get symptomatic COVID-19. Some people still get COVID-19 with the vaccines, but it's likely. I got to be careful with my words. It's likely that even if you do get COVID-19 with the vaccines, you're probably going to have a less severe course of illness. But you still can get infected, and you can still transmit it to others. I would imagine that the quarantine would be lifted when significant proportions of the Canadian population are vaccinated, such that if someone did introduce a case, that it would not start tearing through communities like we're seeing it do now. That's the best I can do for now. As we understand more about how this vaccine impacts transmission and infection, which we'll learn more very closely over the coming months, I think I'll be able to have a much better answer for you.
All right, thank you very much. You actually led right into my second line of questioning with the vaccine, because what kind of vaccine adoption rate do you think the general public would have to have before you could see a significant impact on the COVID infection rates?
Okay, so I think we're going to see significant impact way earlier than what people think. If we get through our NACI level 1 group, which is Indigenous populations, those who live or reside in long-term care facilities, and frontline healthcare providers, we're going to alleviate so much death from COVID-19. We know long-term care facilities account for about 80% of the deaths in the country. By protecting them, we're obviously helping save lives, but we're also taking tremendous pressure off of our healthcare system, which has tremendous ripple effects and benefits for everybody else. So there's a lot of benefit that we'll get early on when they're rolled out, so perhaps by February. Interestingly, even after the first dose of these 2-dose vaccines, we're starting to see evidence that you have some pretty significant protection against getting this infection. It's not as good as 2 doses, but it's certainly a lot better than nothing. So we might see some early benefits with this. But really, we want to have uptake of about 60 to 70% of the Canadian population to really have what we would call something close to herd immunity, where if the virus was introduced, it's not going to start spreading through the community very easily.
Mr. Shipley?
Thank you, Chair. So, and I like your quote, "Relieving death is good." I definitely agree with that one, Doctor. So, a couple more questions about the vaccine, because I know it's been rolled out and it's coming out next week here in Canada, and that's great news. We're all looking forward to that. Nothing negative about that at all. I know they've started it in the UK a little bit ahead of us, but I know there's been a couple glitches, and I'm hearing about it from a few of my constituents about some allergic reactions. Do you have any concerns with these allergic reactions? I have no concern about the vaccine at all. I'll be one of the first in line getting it when it's our turn. But is there any concerns that have been raised to you through these couple of reactions that seem to be getting a lot of publicity right now?
Yeah, I'm not surprised it's getting a lot of publicity because the world is watching closely. And I'm not really concerned about these allergic reactions. We just have to be open, honest, transparent about what we know and what we don't know. We're going to see some things like this happen. We know the two people that had allergic reactions both carry EpiPens and have allergies, severe allergies to certain things. We have to learn more about this. But in the end, I think the pivot where it looks like people who have severe allergic reactions to any component of the vaccine will not be eligible for vaccination. That's kind of obvious, and that's a smart thing to do. And of course, we know that there's other vaccines that are in the pipeline where people who might have an allergy to components of this vaccine will still be able to use other vaccines that are not too far behind. I think we might hear from the Moderna vaccine very shortly here in Canada as well. So yes, a small bump on the road, but by no means is this catastrophic. I think we're going to see the rollout of Pfizer vaccine and other vaccines in Canada.
Thank you, Dr. Bogosh, and thank you, Mr. Shipley. We're now going to go on to the Liberal Party with Mr. Sidhu for 5 minutes. Manny, the floor is yours.
Thank you, Mr. Chair, and thank you to all our witnesses for being with us here today. I want to take a moment to say thank you to all of our healthcare professionals who are working day and night. Dr. Bogosh, it's nice seeing you again. Dr. Bogosh, in your opening remarks, you provided some great insights, and I really appreciate your clarity. My wife and I watch you on the news, as Mr. Shipley was saying. It's awesome. Would you personally feel safe traveling by air for non-essential reasons? If not, what would need to change before you did? I know you mentioned professionally, yeah.
Yeah, I certainly would. I wouldn't do it now because the public health guidance is to stay at home. But I think the fundamental principle is adhere to federal, provincial, and local public health guidance. So I certainly would mention that. But like, if I had to travel, I would, and I wouldn't have an issue with it. I know what to do to stay safe. I'd make sure I'd have a mask on, and my family has masks on. I would be very careful getting to the airport and working my way through the airport in the various junctures along the way where there's potential for crowding. I have confidence in the filtration systems, the systems on the airplanes. I'd keep my hands clean. I'd have situational awareness to make sure that I didn't get too crowded. I'd get off the plane in a careful manner as well. So I would personally have no issues with traveling. But I can appreciate that the general public does have some concerns. And I think perhaps with some educational campaigns and also by decreasing the COVID rates in the community through a variety of mechanisms, vaccine included, but also through strong public health measures, we can certainly boost transportation and instill greater confidence in people traveling.
Thank you for that. Dr. Chagla, you provided information in regards to air exchanges and mentioned flights are relatively safe. You spoke about, international flights. Would you personally feel safe traveling by air, and would you say the risk increases on longer flights, for example, 12 to 16-hour flight versus shorter flights?
Yeah, so it's a good question. Again, as Dr. Bogash said, I would be happy to fly at this point in time, recognizing the other features. I mean, I think, again, the biggest risk factor to flying right now is your destination, particularly knowing what's happening in other parts of the world, rather than necessarily the flight experience and again, being mindful of the other parts. That DoD study was interesting because it kept talking about that fluorescent particles and really that measurement and the filtration and the amount of time they stayed in air to a detectable quantity, about 6 minutes or 2 air exchanges basically. And so if you just take that on a probability map, then yes, the longer you're on that flight and beside someone that's actively infectious, the longer that you may start seeing that exposure as their burden, as their shedding keeps going and going and going, the air exchanges keep going and going and going. The DoD study, they suggested like 54 hours beside a contagious person. I think it's probably, dependent on the viral load of the person, the context, how close you are to them, if they're masked or not masked, that type of thing. But certainly there is a dose relationship. Shorter flights are probably less risk than longer flights where you just have more, even with the air exchanges, you just have more particle exposure.
Mr. Sidhu?
Yes, thank you for that, Dr. Chagla. Mr. Taylor, did you want to weigh in here?
Yeah, I'm delighted to, Mr. Sidhu. I've recently taken a 13-hour flight from Germany over to Mexico and felt completely comfortable on the aircraft. The crew were incredibly well disciplined in enforcing the masking and, as best they could, social distancing. The hygiene of the aircraft was excellent. Obviously, knowing the industry intimately, the protocols that are now in place were and implemented by the airlines help to reduce the risk for all travellers. However, as my two colleagues have said, the risk exists based upon exposure, based upon concentration, based upon a look factor of how many people on that particular flight are infected.
Mr. Taylor, can you lift your mic up a bit more? The interpreter's having a problem. Thank you.
I beg your pardon. Yeah, so as I was saying, there's many factors determining how high or low the risk is on a particular journey.
Thank you for that. Mr. How much time do I have left?
You have about 40 seconds.
Okay, really quickly, Dr. Bogosh, we did, you briefly mentioned quarantines for international travelers. Would you recommend Canada shorten its mandatory quarantine period?
If we had good data demonstrating a negative test on arrival and a negative test at 7 days, we're really going to have very few slip through the cracks. I think it would be completely reasonable.
Thank you, Dr. Bogosh. Thank you, Mr. Sadu. We're now going to move on to the Bloc Québécois. Mr. Barcelou-Duval for 2.5 minutes. The floor is yours.
Thank you, Mr. Chair. Dr. Chagla, if I've understood, you were involved with these tests done in Calgary with the pilot project. There is a pilot project that was done in Toronto. There was another one that was announced for Montreal. Can you explain the differences between those three pilot projects in those three different cities?
So I've McMaster's been involved in the Pearson study. So that's travelers coming off Air Canada flights voluntarily at Pearson Airport. The Calgary pilot is being run by Calgary, provincially in that sense, by the health authorities provincially. So the McMaster study was point of entry testing and then day 7 testing as part of it. It doesn't change quarantine. It just is essentially a data finding expedition in that sense. It is not public health advice tied to it. The Calgary is different in the sense that they're using day 2 testing to release people from quarantine and then also using a day 7 test as a follow-up for those people. They're contracted to actually do the test day 2 and day 7, but they're using the day 2 rapid test to actually take people out of quarantine and then using the fail safe of day 7, telling those people to be very careful about their interactions, but not necessarily imposing a strict quarantine, just masking, minimizing interactions, not going to public places, not seeing vulnerable individuals. And then day 7 getting that secondary test, and if the secondary test is negative, then they can go about their business as normal. And I have to apologize. I don't know what's going on in Montreal. That's you're probably the first to mention it to me in that sense.
OK. Il y a certains pays.
Thank you. Some countries are envisaging asking for a medical certificate for a negative result when they enter the territory. Do you think that would be sufficient for us to do something similar? Maybe this question is for Mr. Bogosh.
Oh my God, that's the hardest question. I really have been thinking about that a lot over the last couple of days, and I honestly can't give you a good answer just yet. I think we need documentation, and we need to ensure public health and public safety, and we need to know if people are infected and pose a risk to the Canadian public. But there certainly are major ethical issues, and I think to really delve deep into that, I would love to speak with medical ethicists and also to really have a good understanding of what the values are of the Canadian population. So I don't mean to punt on this one. I really don't have a good answer for this question, unfortunately.
Thank you, Dr. Bogosh. Thank you, Mr. Barcelou-Duval. We're now going to move on to the NDP. Mr. Bachrach. Mr. Bachrach, you have the floor for 2.5 minutes.
Thank you, Mr. Chair. Dr. Chagla, I'm wondering if you could comment on this idea of travel corridors. I know that other countries such as the UK have are using this idea of travel between countries with low case counts as a way to eliminate the quarantine requirement. Can you comment on the efficacy of that or any issues from your perspective?
Yeah, I mean, so the concept being is you go to lower epidemiology or lower incidence countries, and therefore your risk is not dissimilar to my risk of, driving to Toronto and then driving to Hamilton on a daily basis in that sense. Um, Certainly countries like New Zealand and Australia, I think there's some validity there. The problem is you have to be very in tune to the epidemiology of what's going on. There are regional outbreaks that occur in many different places. There are countries where we just don't know the epidemiology, and it's interesting. Some of the work from the McMaster study is starting to reveal some of these travelers coming back from countries that claim very low incidence, but are actually probably higher than we expect. Um, and the reality is as well, I can't fly to New Zealand on my own from Pearson, right? I have to hop off in an airport, probably in Hong Kong or in Dubai or something along those lines. And so, fine, you were in a low incidence country, but you stepped into a high incidence country in an airport and hung out there for 12 hours and then came back.
My next question, Dr. Chagla, just very briefly, temperature checks. So airports have been, or airlines have been doing temperature checks for quite a while now. Do we have any data on the efficacy of those temperature checks? Are they being effective at identifying people who are carrying the virus?
So one study that was done in the United States that I know of, where they did temperature checks and symptom screens of everyone entering from the airport. Their estimate of effectiveness was 83,000 temperature checks and symptom checks to identify one individual that was positive. So yes, they will pick up people, but you have to consider what the risks are. And to me, also, having a lot of people standing in line waiting to get a symptom screen and a temperature check from an infection control perspective is like, oh God, what is going on here, right? So
I want to try to fit in one more question, if I could, Mr. Chair. Am I out of time? He's giving me the hook. It's on mute though, so I'm just going to go rogue here and ask Mr. Dr. Bogosh about types of aircraft.
Go ahead, go quickly, and if I get a quick answer, go ahead.
I'm wondering about the air exchanges, and those are some pretty impressive numbers that you cited. I believe it was you, Dr. Bogosh. Are those run across a range of different types of aircraft? I fly a lot on small turboprops, and I'm just wondering if those airplanes have similar conditions. Sometimes I feel pretty packed in there with a lot of other people.
Yeah, it's actually pretty interesting. It's going to be different for different planes, and it probably won't be as good on the smaller planes that you're flying on, unfortunately. Sorry.
Thanks for the answer. Thank you, Mr. Chair.
Thank you, Dr. Bogosh. Thank you, Mr. Bachrach. We're now going to move on to the Conservatives. Mrs. Soroka, you're on the floor for 5 minutes.
Thank you, Mr. Chair. Mr. Bogosh, when you started talking about, your trip right from home to the airport and how you're wearing your mask and everything, do you think that face mask and temperature control are going to become standard features now at airports and on the plane, or is this not an option yet?
I mean, I really think this pandemic is going to wind down, and it's going to take some time. But if we just look at the Canadian perspective, as 2020 rolls on and as more and more people get vaccinated and we just see less and less of this and just less impact on the healthcare system and in the community at large, I really think we're going to start to see the lifting of many of our public health restrictions, including allowing for larger gatherings, probably loosening up at the border, and mask mandates probably being lifted. It's going to get better. I mean, it stinks right now, and January is going to be ugly, for lack of a better word. But this will get a lot better as soon as vaccines start to roll out.
I'm just concerned with public perceptions now. Like you said, a lot of this we're doing is just to make sure that people feel safe. It's not necessarily helping as much as you'd think, which kind of surprised me about wearing a mask at a seat with the, you're right, different planes, different ideas, but how the mask really probably isn't beneficial if you don't have anyone sitting close to you, that really the odds of getting an infection are very, very slim.
I think I would say that the masks are certainly helpful, but I really like to think of these as a bundled approach. And, the masks plus the distancing, if you can, plus the ventilation system on the plane, plus the hand hygiene, it really is a bundled approach. It's hard when you start teasing it apart and say, well, I can eliminate this, but I'm going to keep that. I think it starts to fall apart. If we just keep it bundled together, we'll be as safe as possible.
Okay, you also mentioned about, getting to that herd immunity, that 70% of testing. But until we get to that stage, do you think we'll have some type of vaccination passport that says, yes, I've been vaccinated, I now can travel, or I don't have to have these kind of restrictions? Is that a possibility or not?
I certainly think it's a possibility. I just think we really have to have a firm understanding of what the values of Canadians are for that. Certainly, we know people who are vaccinated are very unlikely to get this infection, and if they do get this infection, they probably got to be careful with my words. They're probably less likely to transmit it. But I think we have to gauge the value of Canadians to see if that's something that they would be amenable to, because there certainly are equity issues with that. Not everyone can travel. Not everyone might have access to a vaccine. We're prioritizing the vaccines with different groups. There's going to be enormous equity issues with passports that would have to be addressed.
Okay, thank you for that. Mr. Taylor, you haven't had many questions, so maybe I'll ask you one then. When it comes to your PCR test, you're saying that this is the gold standard. Would you mind telling me the accuracy of your gold test standard of the PCRs?
Okay, accuracy is built upon historic use, and it's the principal product used globally. The actual accuracy is more a question for Dr. Bogash, to be perfectly honest. The efficacy of the test is well established, but if I could hand that to Dr. Bogash or Dr. Chagla, they will give you a more incisive response to this. But we build the most commonly accurate test globally.
Okay.
Right?
Either one.
Yeah. Okay, fair. So the problem to say an exact number is that PCR is the gold standard. So it's hard to compare a gold standard to a gold standard. Some of the early Chinese data suggested 70 to 80% accuracy. That was really poorly constructed test, lots of different reagents, lots of different parts, not great. Better accuracy is probably 90 to 95%. It again depends on where you're getting them in the context of their infection. Very early, very late, you can still miss people. Looking at data from the Public Health Ontario labs, when you test people, the few tests they get serially, and I think it's about they had 8,000 or something like that, where they tested people twice, which often we do in hospital when people are very, very suspicious. They had about 2.5% that flipped over from negative to positive on their next test. So you do miss people. But again, this is the gold standard, so it's hard to say what's better than this in that sense.
Yeah, fair enough.
30 seconds.
Mr. Taylor, then you test various surfaces. Have you discovered how long COVID lasts on a certain surface the longest, or of anything like that?
Yeah, there's plenty of data around, Mr. Skora, about this. An example would be one of the cruise ships that was held in Japan for some time. Post evacuation of the ship, there was residence material there after 17 or 18 days. And that was on multiple types of surfaces, whether that be steel, plastic. However, the substrate does affect the length of time of dwell. So things like plastics tend to hold the viral material longer.
Thank you, Mr. Taylor, and thank you, Mr. Soroka. We're now going to move on to the Liberal Party. Mr. Rogers, the floor is yours for 5 minutes.
Thank you, Mr. Chair, and welcome to our guest. Mr. Taylor, first of all, with your vast knowledge and experience in the area of technology, testing technology, I want to ask you this question. It's my understanding that the federal government has distributed millions of rapid tests across the country, but that provinces have been reluctant to actually use them. I wonder if you could give me some insight to why that might be the case.
Okay, I can answer that quite simply, Mr. Rogers. The Lumen Ultra is not a policymaker. We don't advise on policy. We develop the most accurate test of its type with the PCR program we have. The decision on that is firmly with the policymakers, not with the manufacturer.
Thank you very much. Dr. Bogash, will you have an opinion on that or a comment?
I honestly think that the medical and healthcare professionals are our own worst enemies. I sit on some of these committees and we hear about some of the debates about how we should use this and where we should use this. Whereas from a medical standpoint, you have to be extremely careful. From a public health standpoint, of course, you still need to be careful, but there's a little bit more wiggle room in how you can use these tools. And you can certainly set up protocols to use them. So unfortunately, I think we're treating perhaps a screening tool more as a diagnostic tool. The question we're answering with these is this person at risk of transmitting the infection? Not, is this person infected? It sounds similar, but it's actually quite a different question. So we have ourselves to blame for a lot of this.
And Dr. Chagla, I heard from many people in the airline industry that we should be using rapid testing to get people back in the aircraft. So, you have a comment?
Yeah, I agree. I mean, there's a creativity issue, unfortunately. I think, there's a risk tolerance issue in the medical community for not using these tests. But again, it's, people are not getting tested as appropriately as possible. We're seeing people quarantine and going through that devastation of having to stay in a house for 14 days and not being able to isolate properly. There's so many good use cases for these tests, and so realistically, yeah, I mean, I think there is the federal government bought them in mind for people to be creative and use them, and unfortunately, the medical community and the microbiology community has been a bit more hesitative. Myself and Dr. Bogash have talked about this at length number of times in terms of our own personal stance. But certainly, yeah, I think they have a role in Calgary. They're used for again getting people out of quarantine, and we're getting the data for that. So it's, if it looks successful, that use case is good. That's a great scenario to use them, right?
Okay, thank you very much. And Chair, we got one final question. The Atlantic bubble has been a unique approach we've used here in Atlantic Canada, which of course has been really positive for helping to keep numbers down, controlling the spread of the virus. But it has a major impact, significant impact on airline industry, who have canceled many of the routes in Atlantic Canada, and it's had a major impact on the tourism industry. So I'm wondering if any of you actually could provide your thoughts on this bubble, if it's been successful in your opinion, and the biggest challenges faced, and there are lessons from this, of course, that we could take to Canada or internationally. So I just wanted to get your take on it.
Isaac here, I'll start really quickly. I think congratulations. I think it was largely successful. I appreciate that there have been some hiccups right now, but with good leadership and good public health, and the Atlantic bubble is essentially able to harness its demographic and geographic advantage. I think it would be extremely hard to replicate that in other parts of the country, and I could list off 20 reasons why. It's not impossible. It's just much, much, much harder. Not impossible, but much, much, much harder. Easier to do in the Atlantic bubble. Credit where credit's due. It worked very well.
Dr. Chagla, you want to comment?
Yeah, I mean, I echo everything Dr. Bogash has said. I think both of us have again talked extensively around the Atlantic bubble and what's worked and what hasn't. There are downstream effects, as you say, the tourism industry, imports, and other people's livelihoods. But at the end of it, the Atlantic bubble had a geographic advantage to the rest of Canada, and it was exploited. It was the right approach. It took a lot of leadership. And I think much of the country is envious that it worked that well, and good to you for it.
Thank you, Mr. Rogers.
Thank you very much.
I do want to
appreciate your comments. Yeah.
Thank you, Mr. Rogers. I do want to take this opportunity to thank Dr. Bogash, Dr. Chagla, Mr. Taylor, and all members. It was a very, very good meeting. A lot of great questions, a lot of great information, and hopefully for those that are watching, there was a lot of insight given as well, a lot learned. I do want to, before I do adjourn, want to wish everybody, as this is our last meeting before we enter the holiday season. Tonight is the beginning of Hanukkah, so I do want to wish all those celebrating Hanukkah a happy Hanukkah. Those celebrating Christmas, a Merry Christmas, and of course to all a happy holiday. And to all of you, although sometimes politically we see in different ways and have different ideals and different manners, we're still all Canadians. And being Canadian, we still have Canadian values with that. And of course, those values attribute themselves to good people, good friends, good neighbors. I always say politics is secondary. Us being friends and fellow Canadians is primary. And with that, I wish all of you a very, very happy holiday with your families. a safe holiday, and by all means, get some rest. It's been a long haul since we came back in September, and get a breather. And I very much look forward to seeing all of you when we get back at the latter part of January. So to all of you, have a great holiday, and we look forward to seeing each other in a few weeks.
Thank you, Mr. Chair. Happy Hanukkah, everybody.
Thank you, Mr.
Happy holiday.